Bismillah ar-Rahman ar-Rahim. Hello, good morning. It's really our pleasure and we are really honored to have with us Professor Dr. Khaled Ismail from the Department of Obstetrics and Gynecology, Faculty of Medicine in Pilsen, Charles University, Czech Republic. Dr. Khaled will talk to us today about premenstrual dysphoric disorders, management and diagnosis of the PMS spectrum. Okay, Dr. Khaled, you may start. Okay.
Thank you so much. Thank you for your kind introduction. Thank you all for coming to attend the session. I will do my best to stick to time and finish on time. So my talk is about premenstrual dysphoric disorder. It sounds like a very complex name. A lot of you might know it as severe premenstrual syndrome or PMS. This is over time, this is the rate of affective disorders in men, this graph, and in women. And you see that both of them, as they start from birth till about puberty, they have similar risk of affective disorders. Once puberty happens, the risk for women having affective disorders is much higher than men. And one of the reasons for this is probably hormonal, because this is the only change that happens around puberty when it comes to pubertal changes. This is the PMS timeline. PMS was actually a condition that was noticed a long time ago, 370 BC, before the birth of Christ. So before that, and it was noted by Hippocrates. Hippocrates noticed that there are some changes that affect women, and these changes seem to fade away after the menstruation. His description was a little bit strange. He said, women are subject to intermittent agitations, which make their way from the head to the uterus once they are expelled. Very simple way of thinking about it, but at least he noticed the relationship. Then in the 1930s, the term premenstrual tension, PMT, was introduced. This was changed into the 50s to PMS. But it was not till the 1980s when people started realizing that PMS can be a serious condition. And then in the late 80s, the name was changed by psychiatrists to call it the late luteal phase dysphoric disorder, very long and complex name. Then changed this in the 90s in the DSM-4 revision to premenstrual dysphoric disorder. And this was recently changed again in 2011 to premenstrual disorders in general. This was done by the International Society of Premenstrual Disorders. And I'm privileged and honored to be a member of this society, hence I'm giving you this talk. So this is just to update you about the new classification and the evidence-based management of premenstrual disorders in general, including PMDD, which is the severe psychological end of PMD. PMDD is a serious condition. We had patients in the clinic. I ran a tertiary referral PMDD clinic in the United Kingdom, patients who attempted suicide when they were premenstrual. There are sadly a patient who died, who actually committed suicide and died. And this is somebody who does not have a psychiatric problem. They just have severe PMDD. So when it comes to PMS, the spectrum in general, there are certain things we have to put in mind. Before I started working in that unit and knowing about PMS and doing my PhD in this field, I hated seeing patients with PMS. I hated that because I didn't really know what to do with them. And it's always a problem. And I'll tell you why it's a problem for you when you see them, because most of the patients you diagnose with PMS don't have PMS. And I'll explain this later on. But for you to understand this, there are certain criteria we have to think about. Forget about the type of symptom. We will deal with this when we go to treatment. Irrespective of the symptom, whether it's breast tenderness, bloatedness, tearfulness, agitation, whatever it is, the timing is much more important than the character of the symptom. You have to rate these symptoms prospectively. ما ينفعش أشخص patient based on what she's telling me before. You have to monitor her. There have to be an agreement that, sorry, I can't make a diagnosis now. I'm going to monitor your symptoms, and I'm going to make a diagnosis in 2 or 3 months' time once you complete these charts that I'm going to give you. The symptoms has to be recurring, and the same symptoms. مش شهر breast tenderness وشهر agitation وشهر tearfulness. ممكن يبقى الحاجات دي كلها موجودة, بس they keep recurring. They have to be relieved by menstruation. At least out of the whole month, there will have to be 1 week, 7 days of symptom-free. If people still have symptoms and they get worse premenstrually, this is a different condition, something called PME, premenstrual exacerbation. It's not PMS, and it's managed in a totally different way. But the most important thing, the majority of women will have some form of premenstrual symptoms, but they are mild. Women know that they're going to come on a period because something happens to their body, they feel something, and they know that. But it does not stop them from going to work. It does not make them hit their children. It does not make them fight with their neighbors. It does not make them break things at home. This is slightly different. When it starts affecting your functioning and your relationship with people, then it becomes severe enough to be called PMS or core PMD, as we will call it later on. How does it happen, or why does it happen? First of all, it's all hypotheses. So nothing really is 100% proven. However, there are facts. From its name, premenstrual syndrome, it seems to be related to menstruation or to the cycle, the menstrual cycle. There is no hormone excess or hormone deficiency. So please, if there is one take-home message, when you see a patient with PMS, don't send her to do estrogen, progesterone, or all hormones. You're doing this because you don't know what to do. But when the patient is going to come back to you with the results, you're going to look at them and you still don't know what to do because the hormones can be anything, right? So please don't send the patient for hormones. Okay? It's of no value. Hormones are of value in infertility or other things, but not in PMS. We know that if you stop the cycle because the ovaries are removed or because you put them on GnRH analogs, their symptoms stop if they have true PMS. When women reach the menopause who have had PMS, they stop. If you put them on estrogen, progesterone again as part of HRT, these women will have their symptoms back again. So it's definitely related to the hormonal cycle. So the fact is, it's related to ovulation. Women who don't ovulate and still have a cycle don't have PMS. It's related to ovulation, and the hormone that is related to ovulation is progesterone. It seems to be related to that. A lot of the symptoms are related to progesterone when it comes to symptoms like breast tenderness and bloatedness. But why doesn't everybody have PMS? Because there seems to be a neuroendocrine abnormality within our brain, within our synaptic system in the brain, that is making some women hypersensitive to their normal levels of progesterone. Are you following me? Which neuroendocrine abnormality it is? Quite a few conditions have been suggested as a reason for it, but probably the strongest possibility lies with serotonin. Serotonin changes throughout the menstrual cycle. We know that SSRIs work very well in core PMD and PMS in general. And also genetic studies have shown some genetic polymorphisms in the serotonergic pathway. So serotonin seems to be linked to this. How do we diagnose it? Symptom rating. You have to rate the symptoms prospectively. There are different charts available. The two charts that are very easy to use are one of them is called the Calendar of Premenstrual Experience, COPE, and the other one is the Daily Record of the Severity of Problems, or DRSP. This is an example of a chart. You can download them from the internet. List of symptoms, days of the cycle, and the patient marks the day of her period. She starts from day 1, which is the first day of menstruation. You give the patient 2 or 3 charts of this, and she fills it over the next 2 or 3 months, and she comes back to your clinic. She rates her symptoms on a score of 0, no symptom, 3, very severe symptom. If somebody has true PMS, you'll see something like this. You will see severe symptoms. They start fading away when the period is about to finish. The patient has at least a week free of any symptoms, and then things start creeping up again premenstrual. You can also, on the internet, you can find different, what we call symptometrics. Some of even your mobile phones have applications like this, where you read the symptoms every day and you get a nice chart. You'll have symptoms going up, relieved by menstruation, at least a week free of symptoms, and the same thing happens again and happens again. If you see a pattern like this and the patient's life is affected, then you can diagnose PMS very clearly. So the classification will depend on what the charts look like. This is a depiction of a normal premenstrual symptom, not premenstrual syndrome. Women just getting few symptoms before a period, they settle and life goes on. But this is PMS. These symptoms are severe enough, but you still actually have no symptoms after the menstruation. They go up again and they come down. There are variants, and these variants are a little bit of a problem. A woman had endometrial ablation, a woman had a hysterectomy, but she still has her ovaries. They can still have PMS, but the problem is there is no menstruation. So the patient can't tell you that this is happening before my period. You can't wait for the period. But if you plot it on a chart, it will look like this with no menstruation, but you will have cyclical symptoms. Somebody who is really having very bad days, but then very clear days, and it's very cyclic. You can also have the PMS introduced, as I mentioned, in the menopause, if you start giving cyclical HRT, even to the extent that some patients start noticing that these tablets cause me problems. I'm going to stop these tablets. And they just take the estrogen part and they leave out the progesterone without telling anybody. Of course, this is dangerous because of hyperplasia. This is what you all see in your clinics. This is premenstrual exacerbation. There is cyclicity. It's severe enough to affect the symptoms, but you see the symptoms don't go back to zero. There are always symptoms. They get worse premenstrually. So you just have a premenstrual exacerbation of an underlying problem. You as a gynecologist cannot treat the underlying problem. This underlying problem might be a psychological problem. This underlying problem might be diabetes, might be epilepsy. Any condition can be exacerbated premenstrually. So you have to be dealing with another specialist who can treat the underlying condition, and all what you're going to do is just to treat or try to control the exacerbation. And sometimes somebody comes back to you with a chart with numbers all over it, has no pattern to the period. They have actually a problem. They have a psychiatric problem or a mental health problem. But of course, for many people, it's easier to say I have PMS than to say I have depression or bipolar disorder or whatever it is. That's why it's important sometimes to work close to psychiatrists or psychologists to explore this issue. The biggest important point is that the woman should have at least a week free of symptoms. The two conditions where you don't get this is the premenstrual exacerbation I talked about and the misattribution, which is somebody that has a totally different condition. I did the PMS clinic for 3 years as a tertiary referral center in the UK. Only 1 to 2 out of 10 women we saw in that clinic had PMS. Most of the patients had conditions like this. So you had to treat them within a multidisciplinary service. Symptoms of PMS can be mainly physical or can be psychological. And these are the list of physical symptoms, and these are the list of psychological symptoms. PMS and diet is really quite important. The commonest symptom we saw in our clinic that bothered women was craving for food, especially chocolate. And of course, when somebody comes to a clinic and tell you this, you might sort of be joking about, but it's actually, it has scientific basis. Carbohydrate in general and chocolate in particular increases serotonin levels significantly. So this is happening as a natural compensation, probably without even us knowing. Like sometimes you will put a little bit more salt. Your body is telling you to put more salt. You don't know why this is happening, but you need salt today. Another day you might need something sweet. So this is, their body is telling them that they need actually a high carbohydrate diet. And this happens more so for PMS patients. The problem is that it doesn't last for long. But this is actually a symptom that can be very stressful, especially if this woman is already overweight or obese. Another dietary manipulation that you can use, which is, has been shown to work, are some supplementation, some trace element supplements. And the most important one of them is magnesium. One of the things you can help your patients with, especially the ones who have bloatedness, is to give them magnesium supplementation. Don't give them diuretics, don't give them a thing to take away wind, because the distension is not happening within the bowel, it's happening within the wall of the bowel. So how do we treat PMS? Let's forget about this diet part. How do we treat it as gynecologists? The two things that you have to think of are either to stop ovulation or to correct the neuroendocrine abnormality. You can't really treat it with anything else. So how can we suppress ovulation? For many years, progesterone used to be prescribed a lot for PMS. I recommend you don't use this at all, because for some women, it might have a very small effect. For other women, it will be harmful. It will make their symptoms worse. So don't use it on its own. GnRH analogs, which are things that switch off the ovaries totally, work extremely well. The problem is you can't use them long-term because of the bones. So sometimes you use it as a test. If you monitor the symptoms and this person looks, they have PMS or even premenstrual exacerbation, you want to switch off the ovaries to see how much of the symptoms will improve. This is like the best treatment you have. And then you can actually demonstrate to the woman that this is really, there is something else going on. It's not PMS only. So you can use it as a test. And they seem to work, generation analogs will work whether the symptoms are physical or psychological. And if you are going to use GnRH long-term, I know this does not happen in Egypt. In some European countries, they do this. Then you have to use add-back therapy. You put HRT with it. If you use GnRH and add-back, it seems to still improve PMS without reintroducing the symptoms again. The other possibility to stop ovulation is estrogen. The problem with estrogen, of course, if the woman has a uterus, is the issue of hyperplasia. You can manage this by giving progesterone, but don't give progesterone orally because the woman will have symptoms again. But use a Mirena IUS, and this is actually a nice combination. Either you start with estrogen, if it works, make sure that you put the Mirena in because you can't use it long term, or a better way, which is recommended by the ISPMD, is to start with the Mirena, because in 25 to 30% of women, ovulation will stop. It will cure them on its own. And this is actually a first-line recommended treatment for women who have PMS, especially if it's mainly physical. And if the Mirena does not work on its own, you can add then estrogen to it. And this is actually a very nice combination to use. If you're going to use neuromodulation, the most effective treatment for PMS, whether we like it or not, but this is based on evidence, are SSRIs, like Prozac. And these are different types of SSRIs, and they're 7 times more effective than placebo. They also work extremely fast. You just need to put women on low dose. Sometimes women just need to take it during the luteal phase, not throughout the month, so they don't feel as if they're on an antidepressant. This is just a forest plot showing you the different types of hormonal treatments. Progesterone is the weakest, and sometimes it's harmful. Things like vitamin B6 don't seem to work really very effectively. The 2 best treatments, most effective treatments, are either to suppress ovulation in this context by GnRH analogs, or if you use the combination of Mirena and estrogen. And the other possibility is to use neuromodulation in the form of SSRIs. These are the most effective if you have diagnosed genuine PMS. So in conclusion, please rate symptoms prospectively. If it is core PMS, then the treatment will depend on the type of symptom and their severity. Premenstrual exacerbation is something that catches us all. We keep treating patients who do not have PMS and then think PMS does not exist, or I really don't know what to do. This is a suggested management plan by the ISPMD. If you have core PMD, which is the classic type, cyclical symptoms, a week free of symptoms, and the symptoms are mainly psychological. The woman sits at home for 3 days crying. She doesn't see anybody. The woman is so angry. I had patients who stabbed their husband when she was premenstrual. And this is genuine. I mean, this is a condition. It's the only time that I had a thank you card from a husband when we treated his wife, not from the patient himself. SSRIs, you have to really consider this because these psychological symptoms can be very severe. If they're not effective, then either change the type of SSRI or you just have to go back and reassess the situation. Maybe your diagnosis was not correct because SSRIs are so effective that if they don't work, then maybe your diagnosis is wrong. If the symptoms are mainly physical, the first line of treatment is a Mirena intrauterine system. The Mirena intrauterine system, if it works on its own, great. If it's not effective, then add estrogen. The other alternative, if the woman does not want a Mirena, or she thinks it's too expensive, or you don't want a Mirena, you can try the contraceptive pill if there is no other contraindication. But in this situation, you have to use a pill that has a special type of progesterone called drospirenol. Do you have Yasmin here and Yaz? These are OCPs that have drospirenol, not other types of progesterone. You can use different types. You might still end up actually relying on Mirena if somebody has core PMS. Or of course, they can go and get pregnant if they're trying to get pregnant, because in pregnancy, the PMS resolves at least for a few months. Thank you very much.
Thank you, Dr. Khaled, for your great informative talk. Any questions for Dr. Khaled? Okay.
هل في فرق ما بين الطيب بتاع البروجسترون والديجري or severity of the dysmenorrhea? Difference like
the difference ما بين التايب اوف بروجسترون وايه معلش؟
الديدروجسترون فور اكزامبل الديبوبروفيرا ميزوكسبروجسترون. هل الطيب بتاع البروجسترون
sorry, I'm also an audience. هل في difference ما بين type of progesterone والsymptoms?
severity of the dysmenorrhea?
Absolutely, definitely. There is a very strong correlation between the type of progestogen. So some progestogens will make the symptoms more severe, especially symptoms that are linked to water retention. That's why we're recommending that if you're going to use the oral contraceptive pill to assess what's happening, the best one at the moment that is licensed for the use in PMS is a drostarinone progestogen. The two pills that I'm aware of have drostarinone are Yasmin and Yaz. Yaz, of course, is exactly the same, but with a lower level of estrogen.
Thank you.
Thank you. Any more questions?
Dr. Khaled, thank you for this.
دكتور مصطفى Professor Dr. مصطفى عبد الحميد.
What I should expect from treatment? What is the most common symptoms that will be improved on treatment? Because it is a very heterogeneous syndrome. Up to I have knee pain that recurs every time. I have neck pain that recurs every time. So what can I expect to be improved more so I can counsel the patient in the proper direction? Because sometimes the expectations of the patients are so high.
Absolutely.
And I feel frustrated to the extent that I wish that this patient lost.
Yeah, I know actually. Thank you very much, Professor Mustafa, for this very clinically relevant question. One of the benefits of the prospective diagnosis is that you have, in a way, a contract or a deal with the patient to say, first of all, based on this chart, you have PMS or not. So if, for example, somebody is saying, every month I have knee pain and I can't climb the stairs, and after the period I'm absolutely fine, I can jump and run and nothing happens. And if this is demonstrated, then you have to diagnose physical PMS. It would be a very strange symptom, but let's assume this. But in most of these situations, when you monitor this, you will not see a pattern. In most of these patients who come and complain of vague symptoms or multiple symptoms, or when you ask her about symptoms, you say, oh yeah, I have this as well, I have this as well. Then a lot of them actually don't really have PMS. And at least if this is on a chart, you can clearly say, well, I'm really sorry. The important thing is the cyclicity, and it's not there. You know, obviously, we need to do, if it's something psychological, you need to involve a psychiatrist. But if it is cyclic, all what you aim for is to reduce the symptom to help her to get on with her life. If it's mainly psychological and they have SSRI and it's core PMS, they will actually switch off like this. It takes 48 hours, unlike SSRIs in depression, where it takes 6 weeks. So patients just come and be transformed. That's why SSRIs work in this context. Just if they take it in the retail phase, if they take it for 2 weeks on and 2 weeks off, it still works for them. So I think the charting is extremely important before treatment to make a diagnosis, or even after treatment to monitor the diagnosis. This would be really the only thing I say about symptom rating. And keep these charts. Make sure that you keep them, because it's a record of improvement or no improvement.
Okay. Any more?
Thank you, Dr. Khaled, for this interesting and comprehensive presentation.